Greetings, everyone. So I have the honor of introducing Dr. Michel. He is a current professor emeritus from the Department of Family and Emergency Medicine at the University of Laval in Quebec, a dear friend and colleague to many of us. I could spend so much time talking about his awards and publications, but basically, he's been the Family Medicine Researcher of the Year in 2014, recognized as one of the top 20 pioneers in family medicine research in Canada in 2015, has been doing vasectomy since 1981, has done over 40,000, has published more articles on vasectomy than a humble family doc can even count, and he's taught dozens of us physicians the art of the gentle no-scalpel vasectomy, including teaching me in Quebec almost 20 years ago. So without saying much more, I introduce Michel Labrec.
Thank you so much, John. Actually, you're putting the bar pretty high, but
Oh, all true.
Okay, so I'll just share my screen now, and we'll go directly to the presentation. I think we got it here. So we're going to talk about management of early pain after vasectomy, and put my recipes because, as you will see, there are many things that are not totally evidence-based. Speaker disclosure, I'm a consultant for two companies that are making vasectomy device at that time. So, but we won't be talking about that today. So at the end of the webinar, I would like you to be able to first describe the most common cause of early pain after vasectomy, to identify the cause of early pain, and to prescribe the appropriate treatment. So, but I've got some notice to first. I'm not a pain specialist at all. I do my best with my experience, and you will see that many diagnoses and treatment are not evidence-based, but they are based on my experience. So, but I'll share that with you, and I'll be happy to discuss right after. I will be focusing on early pain. Early pain, I decided it was 0 to 4 weeks. It could be 3 weeks or 6 weeks, but because I extracted data from my database for a clinical database, and I looked at 4 weeks. It makes sense. 1 month is early pain. I will focus on the most common problem. I won't discuss Fournier's gangrene or any problem like that. It's going to be the most common thing. I will not talk about pain occurring after 4 weeks in chronic pain, but some of the diagnosis and some of the treatment may apply to more prolonged pain after vasectomy. And I will not talk about prevention of pain, which is a very important topic. And I've been discussing with John, and we're going to put that on the program at one point as a webinar, 1 hour webinar. That would be very interesting. So I looked first, how often do I encounter those pain? So I extracted the data from the last 16 months from my database. So from January 2023 to last month in May 1st, I did 2,580 vasectomies. And from this cohort, 195 patients, so 7.6% of patients contacted me for anything, any problem. Could be trivial to severe, but any problem. But this is related only to this patient. And of course, during that same period of 16 months, I saw some patient that have been vasectomized a year ago or 6 years ago. And if you look at those patients, it's 53. So it's moving, it's an open cohort. So it's about, I would say 10%, 248, about 10% of the patient I will be seeing in a year for a problem after the vasectomy. This is not early pain after vasectomy. I looked at that, and I put that by the number of contact people had to me. And you'll see that of the 195, 114, so 60%, were contacted me only once, and I was able to manage them, and 95% of those were managed over the phone. But if you see, the first contact was within 4 weeks. It was 76%, 148 of 195. And from those, pain was the major or the most common problem. And 86% of those who contacted me within 4 weeks was for pain. So it gives you an idea of it's the most common reason for consultation. And this is what this is a plan of what are the diagnoses we're having. And the most common diagnosis, and I will say, is it really a diagnosis? It seems to be a basket where we're putting all those patients where we don't know exactly. And I'll talk about acute granuloma or problem that are early, but it's not an infection, it's not an hematoma, it's something that it's sort of a big basket. And you see the infection, 5% of the 128 for infection, congestive epididymitis for what it is, 11%, but non-infectious is 61. And when you look at the total number, the total percent on all the patient of the 2,580, infection is not a lot. It's 0.2%. Hematoma, 0.1. I had 3 small hematoma during that period, but the most common was really non-infectious inflammation. So let's meet 4 of my patients. They have names that are Etienne, David, Pascal, Mathieu. Those are names of people who are under 30, 40s at that time in Quebec. And they're all happy because they had done a nice vasectomy with us, with local anesthesia, with mini needle, no scalpel, vasectomy, and occlusion with thermal cautery, facial interposition, no excision of the vas, and the testicular end is left open. So let's see what happened with Etienne. He calls me 4 days after his vasectomy, and he still had moderate pain on both sides. And he said, you know, my bag is all blue. So how would you evaluate his pain? How do you evaluate the pain? And I just provide you a nice table. That's from a guidelines that was published about 8 years ago. And all the questions you should be asking when you have a patient with pain. So when did it start? Where's the pain? How severe is the pain? And of course, this is, you can see all the nice little faces, but you can use a visual analog scale on 0 to 10. And I commonly ask my patient, how do you qualify it from 0 to 10, the worst pain or no pain at all? Where do you calibrate yourself on that scale? Can use that. So what makes the pain better or worse? The previous treatment, have you been using things? And what's the effect on your physical function and emotional distress and sleep? So that will help you to for the diagnosis, but also for the management of pain. So Etienne, actually, you ask him to come to the office. He lives in Quebec City. And as you see, this is what he was looking. And of course, just by looking at his scrotum, you see there's a lot of ecchymosis. And then you have to make the decision, is it only the skin or is it an hematoma? And the way to do it is to examine the patient. And when I have some people in training, I really insist that when you look at a scrotum, you have 4 things to look at. Look at the vas deferens. A normal early post-vasectomy exam, you will see a little nodule or very small or a deformation with what we do of this of the vas. And you then look at the epididymis, both the head and the tail, and the testicle. And this should be the normal exam. So for Etienne, it's important that you look inside the scrotum and look if there is a lump. If you have a lump larger than 3 centimeters early at 4 days, it's probably an hematoma. And if it's especially if you have with pain and scrotal bruising, so you're looking at that. So how will you manage this hematoma? If it's very large and very early, I would say by the next day, you should probably call the urologist if you're not one. And if you're urologist, you might consider to do drainage. If you have this sort of scrotum, the patient will feel a lot better after a drainage. It's not one of my patients. I'm very happy it's not, but this is something that can happen, and drainage would be most effective to reduce the pain. But if you have a small lump, let's say a 3 centimeter lump, observation will be fine. You have to explain to the patient, and time is our best friend. I'll repeat that. And lumps will take weeks to months to disappear, but the pain will go away a lot faster. And you should do I would say, a multimodal approach of treatment with Tylenol, acetaminophen, NSAID, and depending on the pain, you can, for that sort of problem, you can use narcotics. But frankly, on all the patients I've seen, I don't remember having prescribed narcotics to any of the patients. So usually if you have the other part of the multimodal approach with scrotal support and ice, that should be fine. And talking about ice, what we use in Quebec, it's easy. During the winter, you take a Ziploc, you put some snow in it, and that's a very nice bag. Otherwise, and my staff, they really like the frozen peas. Any company will do the job, and you can use that. But you have to be careful because there was a case published a few years ago. It was an ice pack induced scrotal skin necrosis following the vasectomy. The guy just fell asleep with the bag of ice, and it was an ice pack, and he lost some of his skin. So 20 minutes per hour, okay, and over the underwear or in a towel. So that those instructions are important, because otherwise people will say, I'll put on some ice and that's it. So I made that. And of course, rest and close follow-up for infection. If you have an hematoma, the risk of infection is larger. So you have to follow those people pretty well. I'll show you some data after that. So now let's meet David. And David, actually, he contacted you 6 days after the vasectomy, and he's got some increasing severe pain and swelling on the left side. He's not sure. You asked him about fever. He's not sure if it's, he had some chills, but he's not sure. So the possible diagnosis for that, if you have this sort of story, is you have to eliminate an infection. And fortunately, David was in Quebec City. So I asked him to come to the office, and this is what I found at the office visit. And obviously, you don't have to ask a lot of questions for that. You see, it's an infection. Even I just think it might be an abscess. You could look at him and fluctuating. So when you look at that sort of problem, you're going to have pain. You have a large swelling. The skin, as you see here, will be losing its normal pattern, and you can see that it's almost shiny and red. So that's an infection. So, and the patient can have fever, but most of them, they don't. And what I was saying a moment ago, that when we did that publication, and it was after a webinar, and we looked at the prevalence of infection in the practice, that was from Quebec City. 1 infection out of 5 was associated with an hematoma. So an hematoma is if you have that, you have to be very, very prudent about the infection and do a close follow-up to these patients. So what do? You have to explain, again, your patient, if you're taking care of them, they will be very grateful and they won't be complaining too much about those complications. You don't want to have any, but it happens. So usually I say to my patient, 48 hours to improve with antibiotics, and it might take weeks to totally disappear with the nodule and the mass over there. And the choice of antibiotics is important because you can have as much gram positive and gram negative because you're in the part when if you have a urinary infection, for example, they're gram negative, but you're playing on the skin also, so you can have some gram positive staph or strep that can induce the infection. And the two antibiotic of choice would be levaquin, which is levofloxacin, which is covering the gram positive, or you can use a combination of amoxicillin and clavulanic acid. In some countries, it's called Augmentin. In Canada, it's clavulin and those antibiotics. And you have to do a very close follow-up. And I said to my patient, I'm going to call you in 48 hours. If you have any more problem within that, you contact me, but I will contact you and see how it goes. And it should improve by 48 hours. If it's not, I will either change the antibiotics, combine the antibiotics, or do an exam and see what's happening. Pain relief is really important. NSAID will really help because we know that the patient, when we look at David, it's quite obvious an infection, but sometimes it's not that obvious. And the NSAID will help if there's some inflammation. Scrotal support, ice rest, that's important also. Now let's look at Pascal. Pascal, he contacted me 7 days after his vasectomy. And Pascal, he lives about 500 kilometers from Quebec City in Chibougamau. That's very, very up north in Quebec. So he's telling me that he has moderate pain since morning of day 6. So the morning after, it's worst when he's walking, but he had no pain or almost no pain day 3 to 5. He had a little pain the first 2 days, and then it was going well. He had a normal ejaculation on day 5. Everything was fine, no blood. And the morning after, he started to have that pain. And it was mostly on left side with no sign of infection. So basically, when it's in the first week, always think about infection. Is it possible it's infection? So, but he's back in 500 kilometers in the countryside. So I say, would you please send me a picture of your scrotum? So I do that, and this is what he sent me. So I look at that and said, oh, that's not too bad. No redness, no real swelling. The skin looks good. The opening is ill. So I'd say that's pretty good. So I would say in that case that I would call that a non-infectious inflammation. We used to call that acute granuloma, where we were feeling a lump. And when you examine those patients, and I told you it's the most common diagnosis that I make, but you have a painful, usually mobile, small lump, 1 to 2 centimeters, and you have no sign of infection, but it's painful on the touch. What's the cause? I've been discussing that many times on the network. I'm still fuzzing around. I don't know. It might be the sperms that are making a reaction. So, but that's the most common.
That was why I left in the first place. And
could you please could you please mute your, thank you. So what do we do with that? Well, first of all, you explain to the patient that it's not an infection. It's not a big problem. And the tension goes down. And usually when NSAID, I said the patient, it usually responds very well to NSAID, 48 hours. What is my first choice? I say to the patient, buy a bottle of 100 pills of ibuprofen, no name, 200 milligrams. You take 3 tabs 3 times a day, 9 pills. You say, wow, that's a lot of pills. No, don't worry. It's because it's over the counter. But take 600 milligrams 3 times a day, or you can have naproxen, which is twice a day for 5 to 7 days. Again, support, ice, rest, and close follow-up for infection, especially if it's early in the process. Then you give me a follow-up after that time, or if the pain is going up, you call me. But after 5 to 7 days, if it doesn't respond, and I'm pretty sure that there's no infection, I will use some prednisone. And my recipe is I give 50 milligrams for 7 days, 25 for 7 days, and 12.5 for 7 days. You might forget the last dose, but it gives you time that the pain will subside. You can add Tylenol. And I say to the patient, make sure that you don't have pain. Cut the pain. Cut that right there. Take the pills and don't wait to have pain. Take the Tylenol while you take the prednisone at the same time. Always say to the guy, if you take prednisone, take that in the morning. Otherwise, you won't be sleeping at night. So that's quite important. But let's say that Pascal, who's 500 kilometers from Quebec City, I changed the story a little bit. And if he had swelling and lump on the right side, so he's telling you, I have no fever, but it's a little swell. So I say again, please send me a picture. So this is what he's sending me. So you can see that there's a little redness, a little swelling. Is that an infection? I don't think it is. But for that, what I would do with Pascal at that point, I would say, you have your cellular phone. I'm going to send you a Zoom link, and we're going to do an exam, a very good exam. Sometimes the people say, oh, I'm at work now. Okay, we'll do that at night when you're at home. And you can have a very good idea of what it is, because when you look at it like that, you might say, looks like an infection. But when you do the exam on Zoom with the patient, and you conduct the exam, so we do a self-exam, you can have a better idea of what it is. So I would probably, if I would be seeing this patient, I wouldn't give antibiotics. I would probably wait with a good dose of NSAID for 2 days and see what it is. But you might decide to give some antibiotics also. That would be depending on the situation. But an exam is really, really helping you a lot in this patient. And last, we have Mathieu. Mathieu, he contacts you 25 days after the vasectomy. He is known to have a pretty large varicose cell on the left side, which is very common in men. I would say 3 out of 10 would have that. And he's got pain on the right side since a week. It's worse during the activities, but he has no limitation. And he feels something is painful inside. When he touches, he cannot tell you if there's a lump or no. There's no real sign of infection. The skin is okay, no fever. And he had no risk of STD. So the diagnosis in there, you would have probably 2 diagnoses here. It could be a granuloma, or it could be what we call a congestive epididymitis. And as I told you before, the border between acute inflammation, granuloma, and congestive epididymitis is sort of blurred. So, I mean, well, but you can sometimes, I put the diagnosis in my chart, that what I'm pretty sure. But so in that case, you would probably, by phone, you could probably tell him, okay, anyway, the treatment, if it's acute granuloma inflammation or conjunctivitis, you will start with NSAID. So my first, if I'm over the phone, I will probably give NSAIDs, ibuprofen, and see what's happening. So Mathieu he was like that, he has pain, and with the ibuprofen, he has less pain, but still present after 7 days of ibuprofen. And at that point, Mathieu is in the Quebec City area. I tell him to come and do an exam because it's still present. I want to see what's happening. So this is the exam I've got. He has pain on the right side, not on the left. The left is a little larger, but you can see the veins in there. So he has a varicocele. But when you examine the patient, the granuloma is a lump that you will feel at the operating site. It's usually 1 centimeter. It can go to 2 centimeters, but there's no sign of infection. It's chronic intermittent pain with activities. But the main sign is that he said, this is where I have pain. You feel the lump, and this is where it is. Sometimes the lump is something you don't even feel a lump, but he has pain on the operating site, and I call that a nevroma in that case, because if I don't feel a real lump as a granuloma, I will call that a nevroma. And the treatment, as I said, most of them will go with anti-inflammatory. But if it's present still, not responding, after I would increase the dose, not increase the dose, but increase the length of the NSAID at that point, if the response is not that good. And I would do an infiltration. What I use triamcinolone. I use 20 milligrams, so half a milliliter with lidocaine. And usually the patient he doesn't feel anything there. I say, you might feel a little more, but we'll go on and see what happened. And this is usually pretty effective. Surgical excision would be very, very rare on the 2,500 patient, and I didn't have any who needed that. I remember that's about 4 years ago. The guy was a cyclist, and he was winning sprint with his the pants. It was going up to his groin. It was painful, and we decided they would go for surgery after all the treatment, but it's very rare. The other thing is the exam is key here for what we call congestive epididymitis. Is it congestive? We don't know. I usually tell the guys, you probably are a big producer of sperm. They really like the ID and say that's why you have that. And it could be acute or chronic pain, temporary or intermittent. So the pain is not by itself something that it helps a lot, but usually if it's intermittent with vague, it helps. But it's going to be the exam that will tell you the story. You exam, and usually it's the head of the epididymis that is painful. Sometimes I saw some epididymis of that size, very, very big, very tender. Sometimes it's not that impressive, but this is what you will find in both sides. And I'm talking about people before 4 weeks. You will see probably that more often congestivity, but this diagnosis will be made more often with more chronic patient after 4 weeks, but we can see it before 1 month. For the treatment, the first steps is the ibuprofen. But what I will add at that point, especially if I've been using the ibuprofen, it's still there, I will ask the guy to do some scrotal bath to decrease the production of sperm. And as I said, I like the idea of telling you're a big producer of sperm, we're going to decrease that. They really enjoy it. But I say you have to be you're gonna have to be very compliant to what I'm saying. And what's the recipe? It's I gave them this little chart, and on the chart you will see the water must be at 47 degrees. That with tap water you can do that, but you need a thermometer, as I will show, and it's 45 minutes daily for 3 weeks. So here you see what I give to the patient. I give them the instruction and I say, put your average pain when you start, put the average pain when you finish, and there's a little calendar to help them to remind. So they have to have a thermos with a large opening. Those for the lunch thermos, those who have kids going at school, they all have that. And you need a thermometer, a candy thermometer or meat thermometer. But you see that the temperature is not big. You don't go to deep fry. You will have a problem. So, or you won't have any pain anymore. Other type of pain. I don't know what's that little sign here that I see, but it's funny. Anyway, let's go there. And you then put your scrotum inside the little pot, and then you watch a nice TV series. Game of Thrones is fantastic for that because it's 10 episodes and you have 8 seasons, so you have a lot of things to see. So you sit down and you do your little bath. And so the other thing I will just mention that in France, they've been using a lot of thermal contraception, but you have to keep this device for 15 hours per day. And you have pain in your testicle if you manipulate it too much. It might not be very comfortable, but I'm just mentioning it that if the guy doesn't want to use the hot water, it can be an alternative. And even with the broccoli rubber band, if you don't have this sort of silicone ring, you can use broccoli rubber band to lift up your testicle inside the Now, congestive epididymitis, if it doesn't respond to those treatments, the second step would be all sorts, and it's not in an order, but I would use prednisone at that point. And in the cocktail for the multimodal approach, amitriptyline is very useful. I had some patient that it's just stopped with 20 milligrams or 25 milligrams of amitriptyline. You do that for a couple of months and then you can stop it, and time will help a lot. If you want to reduce, some people I offer the bath and they say, I will never do that. Would you consider to get an injection every 2 weeks of testosterone for 3 months? And this is a treatment that can be an alternative to the bath. And another option, and that would be very, very rarely, I said rare, but even very rarely, is venting, is opening the vas under the previous surgical site, but just opening the vas to let the pressure out of the epididymis. I had a few patients over the years, very, very few. Most of them, I never heard of them after that. That was a good sign. But I know one patient, he was worse after that. So it's not a panacea. And then the last thing, you call CJO in Florida, and you ask him to do a spermatic club with denervation, or if you have access, but this is very rare. And the vasectomy reversal. I don't know what's happening. I see some drawing on my screen. Do you see that? Someone is putting some drawing on my screen. Can you see that, John? I don't know what's happening. I'm not doing that. Anyway, so I looked at how often I was using those approach. And you see, I'm not using them very, very much. Scrotal bath on the 195, because I put everybody, all the chronic patient also, not the only the 0 to 4 weeks patient. And you see it's 5%. I prescribed scrotal bat, prednisone 6%, infiltration, that was 4 patient, 2%, amitriptyline 2 patient, testosterone 2 patient. So actually, most of the patient will respond very, very well to NSAID and time that you're working. And you see that the scrotal bat, I just prescribed to 2 out of the 10 were in the first weeks. So I'm just going to the chronic, but just to give you an idea. But in acute pain, you won't be using those approach very much. So the key message is pain is the most frequent cause of contact in the first 4 weeks after vasectomy. So we have to be ready to take care of those patients. And non-infectious inflammation as a basket of a lot of things, but is the most common diagnosis. Many cases can be managed by phone, but physical exam is often required for precise diagnosis. It's best to use multimodal approaches at the same time to cut the pain. You don't want you want the patient to have no pain. If the patient gets in that cycle, it will go in his brain, and it's not very. It will be counterproductive of just giving a little shot of painkiller. Better and NSAID time and tender loving care to your patient is our best ally. Thank you.
Thank you, Michel, for your fantastic presentation as usual. Should we open up for questions now? We can take questions in the comments section.
There is, John, there is a one hand raised. Urania Contreras.
Hi, hello. We have patients with pain like yours, and we use anti-inflammatory enzymatic. Have you ever considered to use in your patients? Because our patients, we have patients with positive outcomes with that treatment. We use it like for 15 days on granulomas or with the small hematomas, and we have positive outcomes. So have you ever considered to use it?
To use what?
Anti-inflammatory enzymatics like ribotrypsin or
No, I have no experience on that at all. Maybe some other people in the participant have, but I would love to see what's coming that from, any publication or any
No, we just like start like a protocol because our patient came with pain because after vasectomy they feel free to do anything. So they don't use scrotal support like we tell them to do. So they return with pain and sometimes with a little lump, and we use that kind of medication for 15 days. We see them for 2 weeks every week.
Yeah.
To do the follow-ups, and the lump reduce completely and the pain disappear.
Okay. Oh, wow. Where are you located, Urania?
I'm here in Guadalajara. I work on Tonalá in the health department in Secretaría de Salud.
Very good. So that would be very interesting. If you could share that on the network, if you could just drop a line on the network, and I'm pretty sure it will lead to very interesting conversation related to this, because that's an approach I never experiment, and I don't know if other participants have been, but thank you for sharing.
Because we have our database with that we registered every patient with that
Yep.
problem, any problem. So I can do statistics for you.
Oh, thank you.
For everyone.
I'll compare. I will compare to mine, and we
Yeah.
see, we can share that on the network. That would be
Yes.
most interesting. Thank you.
Thank you.
And then we have a question in the comments. Have there ever been examples of chronic pain after vasectomy? And the answer is yes, it's fairly rare. That's a whole different topic. I'm posting a review article on chronic pain syndromes after vasectomy in the comments section, which will be a nice overview, but we could do a whole presentation on that. But
Actually, the first webinar we did 2 years ago was on that topic, and we might come back because this is a problem. And when I was looking at my database, I could identify a couple of patients, but it probably on 195, it was probably 3 or 4 patients that I could identify that would be really bothersome. And so on 2,000, it means probably 1 out of 500 or more or less. So.
And I think many of us who do lots of vasectomies would answer the question, are there ever cases of chronic pain after vasectomy, by saying yes.
Yes.
And the prevalence depends on how you define the topic.
Exactly. We have a question, Fanny Nobert.
Oh, thank you very much. I think you're able to hear me very well. Are you able to hear me? Oh, okay. Like I remember attending the last episode when you people were educating about the vasectomy process, and I remember like the process where they were cutting the vas difference, and there was some tying of it afterwards. And then there was the aspect of the epididymal hypertension, like if there's continued production of like the spermatozoa, and they will accumulate in the epididymis, and sometimes it causes like that condition of epididymal hypertension. So I wanted to ask, how significant is it, and how do you go about it? Thank you.
That's a good question, Fanny. Actually, the technique we do is what we call open-end vasectomy. And theoretically, because we don't have a lot of good science about that it could reduce the pain on the back pressure on the epididymis if you leave the testicular end open. As I presented, it happens, and we call that, if the pain is located on the epididymis, we call it congestive epididymitis. As you notice in my statistic, is not as common as I thought, especially not in early pain. In chronic pain, it might be higher. The percentage might be higher. I would estimate probably to 1 or 2% of the patient, no more than that, would suffer that with different levels of symptoms. So, but yes, it can happen.
Thank you very much.
And you have to conceal the patient. I usually, in my counseling little discourse that I give to the patient, I usually that prolonged pain would be maybe 1% of the patient will have prolonged pain if they have a vasectomy. That's part of the risk of it. Thank you.
Okay. Thank you very much.
Thank you. John, I'm going to have to leave. I'll leave the floor to maybe Chick, if you have 1 minute comment or question, I will take it.
Yes, Michelle, I just wanted to throw out there that I don't think we have good evidence that epididymal hypertension actually exists in the sense that there's increased pressure in the epididymis. I like to think of it as stasis. And whether the stasis is associated with pressure or not is undetermined. But I think that the inflammation probably is related to stasis and reabsorption of debris and cells in the epididymis. And I think that there may not even be any pressure. But when you cut the vas and discontinue cell to cell conduction that mediates the propagation of vasal contractions, then that may just simply lead to stasis. Just like think of stasis in the bowel when that occurs.
No, I totally agree with you. And even you probably in your practice saw some granuloma in the tail of the epididymis. People that have that problem, and many years after the vasectomy, they have some granuloma. So there might be a micro destruction inside of the epididymis that we don't see. And as you said, it's probably not congestive, but there might be some inflammation in the epididymis because
I think nodular malformation of the epididymis is quite common after vasectomy that you don't see in people without vasectomy.
Yeah. Thank you for your comment. So I'm good. I'm going to take care of my patient, of my Etienne, David, Pascal, and all of them for this afternoon. Thank you very much.
Terrific.
Bye.
Bye. Thank you, Michel. Fantastic as usual.
Thank you.
So we have a question from the audience in the comments section. Is there a particular technique that may be associated with less post-vasectomy pain? And the data that we have on minimizing post-surgical pain points out several techniques. One is, of course, the most gentle, minimally inflammatory technique you can possibly do. So over and over again, it seems like the no scalpel technique wins when you're talking about creating less post-vasectomy pain. Also, there's many articles that point out perceived pain during a procedure is related to pain perceived after the procedure. So the more liberal we can be with achieving excellent pain control during the procedure helps the patient's perception of pain after the procedure. So those are the two evidence-based answers, that basically the least invasive technique we can do with the least manipulation of tissue and causing inflammation, and also the best pain control we can use during the procedure. So making sure that we don't just push through the procedure when the patient says they're feeling something, but stop and giving them a top off of anesthesia if they feel anything. And then there's some articles that discuss using a pain medication after the procedure prophylactically may have an effect on pain perceived over the next few days. So basically keeping on top of it. Other questions in the comment section?
Hi, John. I would I would only add that I used to wonder whether gathering a large amount of tissue during fascial interposition predisposed to pain.
That was a fantastic study you did.
Yeah, over a period of 1 or 2 weeks, my daughter, who was a pre-medical or medical student at the time, joined me on many vasectomies. I think it was 30 or 40 vasectomies, and actually took pictures, close-up pictures of how much tissue I was gathering to perform fascial interposition. And then she called those patients at day 1, day 4, and day 10, and asked them on a scale of 1 to 10 how much pain they were having. And while we didn't actually publish this information, it was sort of useful to my own practice and to my own sense of, should I be concerned? The fact was that there really was no correlation, which is sort of almost counterintuitive. You would think that the more tissue that you bundled in your fascial closure, whether you're using hemoclips or ties, the more likely they would be to have pain. But there was absolutely no correlation to that. So for those of you who might be concerned, I think you should gather enough tissue so that you don't get a hematoma. Because a lot of times the sheath there's a lot of clingy vessels in clingy sheaths, and it's, by the time you get done taking those vessels away from the vas, you've got quite a bundle of vascular tissue there, and you really don't want it to bleed. So you gather up a bunch of it in your fascial closure. And I would suggest to you that do what's safe to prevent bleeding. Don't worry. that more tissue in your fascial closure is going to result in more pain.
Exactly. We could certainly say, as an understatement, hematomas increase the rate of post-vasectomy pain.
That's right, for sure.
And then we have a question in the comments section about, is there a medication that is better for post-vasectomy pain? This hasn't been looked at in a super rigorous way for post-vasectomy pain, but it's been looked at in a fairly rigorous way for other procedures. I'm posting a link in the comments section that has a link to the Cochrane review of NSAIDs versus acetaminophen or paracetamol in other countries. That link to the Cochrane review, which is a very good detailed review of medications using comparing NSAIDs to paracetamol, says basically there's not much difference, but it's worthwhile to look at the edges of the data. But if you use paracetamol afterwards, fantastic. If you use NSAIDs afterwards, fantastic. The data doesn't push us either way in a dramatic way for prevention of post-surgical pain.
I think it's common knowledge now, but I don't think it's been mentioned today that you could go over it yourself, alternating doses of acetaminophen and ibuprofen. I leave that to you.
Absolutely. Doug points out that that we can actually use both, and there's some data to support using both NSAIDs and paracetamol or acetaminophen for post-surgical pain, for the prevention or treatment of post-surgical pain. They don't interact in a bad way. For example, the NSAIDs have more GI effects and the paracetamol has more liver effects, but they don't synergize. They don't cause increasing effects of either one. So there are many of us who will use alternating doses or even combined doses of NSAIDs like ibuprofen plus paracetamol or acetaminophen. And because they don't interact in a significant way, that's another great way to minimize or treat post-surgical pain.
Yeah, and by alternating doses, we mean a dose of 1,000 milligrams of acetaminophen every 8 hours, and a dose of the NSAID every 8 hours, but 4 hours apart. So
Right.
You're still getting the normal therapeutic dose, but you're not taking all that medication all at one time.
Absolutely.
You're taking it at 4-hour intervals.
Absolutely. And there's a question in the comments about, do we use longer acting NSAIDs like Mobic? And I think many of us, as Michelle points out, use ibuprofen in our countries just because it is very, very inexpensive. And lots of our patients can't afford the more expensive NSAIDs, or it just becomes more complicated. And ibuprofen is available over the counter. So I don't have this as a super evidence-based answer, but I can say that very many of us use ibuprofen just because it's super inexpensive, very cheap for our patients. Other questions? Is Catherine watching the hands up?
Lisa, please go ahead.
Thank you so much, Dr. John, and Michelle. Definitely a very wonderful presentation. Just a very quick question. So there is something that I've observed over time that for clients here in Uganda that we've given post vasectomy injection of a steroid, either low dose dexamethasone or low dose methylpred, we've had actually fewer cases of clients calling back with pain post procedure. Is there a particular rationale, or it should be common practice? Should it be part of the protocol that each time we do a vasectomy with a client, we should follow it up with a very low dose single injection of either methylpred or dexamethasone to see that we do not get cases of pain being a problem? Then the last one, how do we avoid epididymal congestion post vasectomy?
So I think those two questions, great questions. Should we be using a post-procedure corticosteroid after minor surgical procedures? And I think the standard of care for most of us in the US is that we do not prophylactically use a corticosteroid after minor surgical procedures. I think They have a slight infection risk, but I have not seen a head-to-head study of using corticosteroids after minor surgical procedures like a vasectomy. I know there is no study where we've looked specifically at vasectomy. It's an interesting idea. It just hasn't been studied yet. And I think many of us would say, let's not leap into things we don't know yet. But it's a fascinating idea. I don't know of people who do it. And then the next question is, what can we do to minimize epididymal congestion? As Michelle points out, good that we actually don't know, and also Chick Wilson pointed out, we don't know what that epididymal soreness after the procedure really is. Is it congestion? Is it just inflammation? We believe that if you use an open-ended testicular end, that we reduce the rate. The data is not super clear on that. So basically, because it's such it's a condition that goes away mostly by itself or goes away with NSAIDs, we haven't really made a huge study on how to prevent it yet. But basically, knowing that it's rare, knowing that we do the least invasive technique we can, and knowing that afterwards we can treat with NSAIDs helps a lot. So both of the answers I gave you were a little bit wishy-washy. I apologize. I'm trying to keep very evidence-based, but they're terrific questions.
Hey,
Other
John.
questions, other hands up?
I had a question, John.
Terrific.
Not a question. I'm really just first of all, thanks. Fantastic again, as always. 340 people, 350. I think we passed 360 people. I don't know if that anybody could ever claim that many people for Saturday morning. I know Saturday afternoon in some places and evening in others as well. So it's awesome to have such a great turnout. Before we went on, and I know that everybody wants to get on with their day, and it's Father's Day weekend, so we wanted to acknowledge that for everybody who's celebrating their own fathers, or if they are fathers, just to have that day. It's not everywhere in the world, but in many parts, it's Father's Day. I want to just take the moment to introduce Isabel Galeano. She just started working. She finished helping me with the road trip, with Escar's road trip to the heartland of America. Now she's working as the director for development. So I just want to introduce her, and she wanted to share a few words before we headed off. So Isabel, I pass the word on to you.
Hello, everyone. My name is Isabel Galeano. I've been collaborating with the organization since 2023 from Tanzania at that time. Now I am leading the fundraising team, and I'm very excited about it. As Jonathan has presented at the beginning of this webinar, we will be pushing really hard this year for it, and we are looking to create actually a sustainable path for the organization. So you will be seeing me all over now. So I'm in charge of this, and thank you for your collaboration. And we're just looking to spread the word and just tell everybody what we're doing and trying to get funds to develop our projects. Thank you so much to everyone to assist today. Thank you.
So, sorry, just a quick question. This is Jethro from the University of Nairobi. We're wondering how you deal with the antigen antibody reactions that occur in some men, or as a section of population of men post vasectomy, at least from what you have done and from your practice. Thank you.
Terrific. So very good question. The question is, what do we do about the potential for antigen antibody reactions that could occur theoretically after a vasectomy, in the sense that the patient after a vasectomy has now been exposed to sperm, and there may be antibodies. As far as we know, if you develop antibodies to sperm, it doesn't have a clinical significance. If you have a mild inflammation to your epididymis, as we've talked about the epididymal congestion, and Chick Wilson pointed out that it may not be congestion or increased pressure, it may just be a slight inflammatory response. There's really not much to do about that. It doesn't affect a patient's life, yeah, I have not seen anybody who particularly tries to prevent it, or anybody or any patient who's ever come back after 20,000 who's ever said, I'm having a clinically significant effect of anti-sperm antibodies. So it's something that could be open for research if somebody had funding to see if there's any correlation between antibodies to sperm and any clinical outcome, but I haven't seen any indication that making antibodies to sperm has a adverse clinical outcome. So far, we don't do anything about it because we don't have great data, and also we haven't seen a clinical effect.
So there's no role of pharmacological agents or any chemotherapeutic agents post vasectomy, at least in that regard.
In that regard, no. In the regard, there's a role for chemical agents, for example, non-steroidal anti-inflammatories or paracetamol for pain control. But in terms of preventing formation of antibodies, I don't think I have not seen any studies that show that that's useful. And it would basically be introducing a chemical agent for a theoretic issue that we haven't seen has a negative clinical outcome.
All right, thank you so much.
Oh, of course. And the answers that I give, I've tried to review the evidence very thoroughly on these topics before the presentation. But if anybody has other data to suggest differently, we're a group that's very open to learning from each other. So what I say is not to be considered gospel truth, but just the best review that I can do of the data. And we try to keep humble about our answers. Yes, good, Dr. Wilson, unmute.
Yeah, hi, John. I just want to say I agree with your answer completely, and I was trying to remember, and other people may have better memory than I, but this is there's data on this, and it's old, and I can't quite recall it all. But as I think about it, what they found was that there are anti-sperm antibodies in men, both who have had vasectomy and who haven't had vasectomy, and on average, the levels are higher in men who've had vasectomy. But as you said, they found no clinical effect of anti-sperm antibody in those men in terms of invoking any other type of disease or disorder. So there was a feeling that there's no need to treat for that. And back to the idea of congestive epididymitis, I might have misstated it a bit. I do think there's congestion in the epididymis, probably, but whether there's actually pressure, whether that means pressure or just stasis, just accumulation without pressure, as in an ileus in the gut, where it's huge and it's filled with fluid, but there's no pressure in it. It's because there's no muscular pressure, muscular tension in the wall of the gut. I think similarly, it may be a lack of tension in the wall of the vas that leads to the stasis and congestion in congestive epididymitis.
Well said. Now, there are a few questions in the comments about, for example, what can we do about community-based interventions to empower women to make decisions about to help with promotion of vasectomy? That one, I'm so happy to talk about that off of this conversation. Boy, that's a long and beautiful conversation that World Vasectomy Day has been working on for a very long time to try to get everybody involved with decisions about contraception, not just men, not just women, but to have a joint effort. So I think Jonathan Stack has been leading the effort to get people of both genders talking about vasectomy and talking about reproductive health in a positive way.
Can I just say one thing about that?
Please.
Because it's not leading the way. There are people all over, the
Absolutely.
people on the field working. But Sheila Gebeya, I don't know if she's with us now, or Zulu, if you're here, but in Zambia, they've created this thing called the Responsible Men's Club, and some of the women felt like they wanted to be included. So the men's club was both about trying to aggregate these men who had already gotten a vasectomy and now were taking on a leadership role, going around community to community to tell their story and to educate men. And the women and the wives of a couple of the men said, we want to have our own group. So it's like a responsible women's club. Again, it's sort of to create and to get women talking to other women, because the women are very much a part of the conversation. In many places, they're the leaders of it. So we very much appreciate that question. And it's certainly at the heart of a lot of what we're doing.
Fantastic. And part of what I mentioned, and Michelle is very good about mentioning, is we try to keep things evidence-based. I'm posting in the comments section for everyone. I'm posting in the comments section a link to an educational website that just has some articles that are very pertinent to this talk, basically comparing NSAIDs and acetaminophen, looking at the Pain Society's guidelines for optimizing pain control after procedures. Basically, this is a list of a very few articles that gives much evidence behind what Michelle has been saying. So if folks wanted to download those will be available for the next few days on this educational website just for a free download if people want to look at the data behind what we've been talking about. And I think we're way past time. What a delightful group. Thank you everybody for coming. And are there any? We have somebody who's asked, do you think all providers keep similar pain data? I know that in many of our practices, given inspiration from Michelle and other very evidence-based researchers, many of us do keep logs now about what happens after our procedures. And I don't think all of us do, but I highly recommend keeping a spreadsheet about your phone calls and about your visits after the procedure, or if you use an electronic medical record, keeping these records, because it really helps you figure out things. For example, one thing I figured out by keeping records, I was using silk for a very long time for my fascial interposition. When I used silk, I got more phone calls about inflammation and a little bump above each testis than when I switched to a minimally inflammatory ligation using either Vicryl or Polysorb. So by looking at my data, I was able to make a small change that didn't cost much, and I got fewer phone calls and the patients were more comfortable. So the question is, do we think all providers maintain the records about their phone calls and visits after procedures? I do not think we do, but should we? The answer is yes. It's super useful for us to keep those records. Catherine, do you see any more hands up?
No, John, we are going to present the video to close the session.
Oh, terrific.
Thank you, everyone.
Thank you, everyone.
A vasectomy is an act of love, an individual decision, an agreement between the couple, a shared responsibility, and a dedication to a better future. And when this act of love embraces a global community, it becomes a catalyst for change. Through vasectomies, men take an active role in family planning, rising up for themselves, their partner, and their family. World Vasectomy Day celebrates men as partners, doctors as leaders, and families as agents of change. We invest in building capacity, educating the public, and advocating. When you support World Vasectomy Day, you help create a world where love extends beyond borders. Because when love drives change, the world becomes a better place. Everyone.